We've got a great lineup. We've got Dr. Hassanein will start us off. Then we'll go with about liver disease. Then we'll have Dr. Dunford, who will talk about alcohol use disorder. And then we'll have Dr. Wang from UCSF, who will talk about some emergency medicine and some really great research they've done with medication-assisted treatment. So with that, let me kick things off with Dr. Tarek Hassanein. Dr. Hassanein is a longtime supporter of the liver disease community and serves on our medical advisory council, and also aligned with the liver centers, the Southern California Liver Centers, and then working with SHARP and UCSD. So with that, thank you so much for being here, Dr. Hassanein, and I hand the mic over to you.
Okay, thank you. Good morning. And thank you, Scott. I would love to extend my appreciation and privilege to be working with the Liver Coalition and Scott and the effort they have done in liver disease. Hepatitis C has been a major issue. They have done significant work in promoting the treatment of hepatitis C to the point that we need to eliminate hepatitis C from San Diego County. And now we are paying a little bit more attention about alcoholic and alcohol liver disease, which became a major problem. You're going to see it's becoming a more important problem. The issue is that it's affecting our young individuals more than the old. And it is affecting a sector of patients who we consider disadvantaged. And we can help, and we can save a lot of these patients from dying prematurely. And hopefully by the end of today's sessions, you can get an idea where the patient should go and how we can help them, all of us. So let's get going. Alcohol, all of us drink alcohol, and you just need to know whatever alcohol we drink, it's gonna get metabolized in the liver, eliminated by the kidney and the lungs. That's why we can smell it in the breath, we can smell it in the urine. Mostly 90% oxidized in the liver, and the liver, when it gets exposed to alcohol, depends on the amount and how fast the person is drinking. It really affects every metabolic step in the liver, and it leads to a lot of toxins. Just to remind you, we used to call people who drinks a lot, they have alcoholism. Now these terms are changing. We call it alcohol use disorder, and you're gonna hear more about it. Even alcoholic liver disease, we call it alcohol-associated liver disease. And there's a form of alcohol-associated liver disease called alcoholic hepatitis, which kills people very fast in a matter of weeks. That's what we call it, alcoholic-associated hepatitis, AH. Alcohol, very common all over the world. The north, you can see all the civilized societies, they have a lot of alcohol use, and here it correlates to the high levels of patients presenting with cirrhosis, and we know that. Now, what is the most common question is, how much is too much? And when we look at, for women, more than one drink a day is too much. For men, more than 2 drinks is too much. If someone drinks, if a female drinks more than 4 drinks, or a male more than 5 drinks in one session, we call it binge drinking. And heavy drinking, 8 to 10 drinks. What do we mean by drink? A standard drink is 12 to 14 grams of alcohol. So 1 beer is considered a 12 to 14 grams of alcohol, equivalent to a glass of wine to a shot of liquor. So you can imagine when we ask our patients, so how often you drink, and we have all these different ways to assess drinking, we ask about the number of drinks multiplied by the number of grams, and we know how much roughly they are drinking. What happened lately, and this is very important because the COVID pandemic really underscored the importance of that condition, because we started to see a lot of people dying from drink. So now we have an estimated 14.5 million people who have alcohol use disorder. Almost 100,000 die a year, cost almost $250 billion in cost. Here's the most important piece of information, is the bottom line. Alcohol liver disease is contributing to increasing liver disease-related mortality, particularly among people aged 25 to 35. We are talking about that group. They present with acute alcoholic hepatitis. A lot of them have issues that we're going to discuss today and see how we can help that group and never give up on them. Sales of alcohol going up. Very clear that you can imagine that particularly females were more engaged in an increased frequency of alcohol consumption and binge drinking over the last few years, because we relate some of this to the COVID pandemic. And here you can see that the number of hospitalization of patients has increased significantly. 62% increase in inter-hospital patient transfers from the pre-COVID to the post-COVID. Now it's declining. However, when you look at inpatient liver census in the hospital with alcohol liver disease, has increased significantly from 35% pre-COVID to almost close to 50% during the COVID time, at the peak of the COVID time, and now it is declining, but it's still almost 40% of what we see. This is the liver cell. When you drink any alcohol and it goes to the liver, it almost affects all the metabolic pathways. What does this mean clinically? Initially, I go out drinking over a weekend. Even if I do some binge drinking, I might have some abdominal discomfort. But what happens immediately, my liver starts showing too much fat in it. And, I stay without drinking for a week. It starts to go away. Then I go to the next drinking episode. And over time, I have a chance of 10 to 35% of developing acute alcoholic hepatitis and progressing over the number of years to cirrhosis. So we know that there's a major issue. And if you look at the projected alcohol-related issues, morbidity and mortality is more during the COVID, additional 8,000 additional liver-related deaths, 18,000 additional decompensated liver, 1,000 cases increase in liver cancer, and 8.9 million disability adjusted life years between 2020 and 2040. We have a problem and we need to address it. We talked about the alcohol makes the liver inflamed. How? Through different mechanisms, cytokines, immune system, oxidative stress. The worst presentation is what we call acute alcoholic hepatitis. Now, as a physiology, I'm not going to go through all this, but I'm telling you, the alcohol injury, the liver has the tendency to come back, but the alcohol affects the regeneration. It affects how our intestine works. It affects the bacteria, and every one of us hears about microbiota and the bacteria in the gut and how it changes, and how the change in this bacteria, especially in patients who are drinking a lot of alcohol, leads to more liver injury. This is the bottom line. The acute alcoholic hepatitis is what I tell my patients is the liver on fire. It's burning. The patient comes to me in a state of acute alcoholic hepatitis. His liver is literally burning, fire, liver on fire. And it takes time to subside. And I need to keep my patient alive over these next few weeks till the fire subsides and the liver get a chance to recover. When you look at meta-analysis of over 6,000 of these patients in 77 studies, within the first 28 days, 26% die. By 90 days, almost 30% die. By 128 days, almost 44% die. So that cause of death, and even up till today, we urgently need effective treatments because we have no treatments. Can we easily diagnose it? Yes, very easy. Someone showed up, or I have been drinking the last few weeks. Now they are yellow. They have abdominal pain. some manifestation of portal hypertension, the white count is elevated, and every doctor knows how to say, oh, this is acute liver injury. The issue is, if they come early to the ER doctor tells them, stop drinking, come back if you get more sick. And now we are losing a chance to recover these patients. If they come back and they are more sick, oh, we don't have any treatment, let's give you some steroids. And so I'm gonna touch base about this because that's not the right way of handling these patients. Very clearly, we have a group that showed that we can save 100% of them. And there's a group that the mortality is as high as 50%, depending on how severe the liver is injured. We have ways to predict how severe the liver is injured, and we have ways and models to predict who is gonna live and who's gonna die. The issue are these models are not well known in the ERs, they are not well known on the floors with the hospitalists and GI and liver specialists. They use these tools to figure it out. It's a significant public health burden. And you're talking here about dying in the hospital from liver disease is costly. I always said that for the last 30 years. Dying from liver disease is expensive. Here's a patient comes to the hospital with alcoholic liver injury and they die, $150,000 in expense. If they get discharged within 5 days, it's still $53,000, very expensive. What happened during the pandemic? If you look at the first curve, more women are drinking than men, and it became very clear during that time. And when you look to the second colored curve, you see that the age less than 40 has been the group that is increasing, and the group that is above 60 is almost the same. So to a certain extent, younger people, more women are drinking, and they are more susceptible to get into these issues of acute alcoholic hepatitis. When we look at mortality from the 70s to now, we haven't changed mortality. We haven't changed the 28-day mortality. We haven't changed the 3 months mortality. We haven't changed the 6 months mortality. What does this mean? It means that we need better management and better treatment, and we need more specialized types of approaches to these patients. So to a certain extent, the most important treatment, abstinence. How can I get my patient abstinence? With you and the next two speakers, and with our work as a group, we can help our patients and their families to keep them abstinent. Better nutrition, because when they drink, they don't eat, and the drinking itself gives them a lot of calories. Now, liver transplant can save any of these patients, but corticosteroids, they show up in the ER, they give them steroids. Not every patient is a candidate for steroids. Actually, steroids can make their condition worse if they are not the right candidate. Now we are doing this beautiful study with a DOR 928, and that's larsucosterol, which is an epigenetic molecule that our body produces when it gets stressed and cells gets to die, and that to help the body to recover. Now we give it, and our initial trial here that was done in San Diego and in other places in the country, and we were lead center in it, showed that our patient improved, and I'm going to show a couple of data. When everything fails, I put them on the dialysis machine, the albumin, ECAD, extracorporeal albumin dialysis, and if it's not available, you can put them on plasmapheresis. Steroids and pentoxifylline, which were commonly used, shows that they didn't change much, but they're definitely a very small group of patients, almost around 20% of the patient we see, they can benefit from steroids. Here's a study that we did on the efficacy of the DOR 928, and it shows clearly significant improvement in serum bilirubin and the impressive improvement in MELD, especially when the patients are very sick. Now, this initial study translates in the much larger study, national, international, global study that is going on. using that molecule to prove its efficacy. What do we do when we put them on albumin dialysis, which we have been doing since the 2010? You can, from 2010, we started this work at UCSD for patients in hepatic coma, and now we tend to use this system, and very clearly, early in the studies, that the ECAD using the Mars device compared to control had a significant difference in survival. That study in Germany was stopped because it was unethical to keep randomizing people between the ECAD using Mars and no support. So what do I do when a patient comes in? A patient comes in, we evaluate them. Are they candidate for steroids or not? If they are candidate for steroids, we give them steroids. We watch them over 7 days. It's not, here's the steroid prescription, go back, come back in 30 days. Doesn't work that way. 7 days, we have to make a decision about the steroids. If it's working, we continue for 28 days. If it's not working, then we need to move to the next level. Either we add to the steroid snack, or we put them in a clinical trial, or if we fail everything, we put them in the machine, and then we consider them for transplant. What's my problem with transplant? You know, the transplant center says, you know, I need 6 months sobriety. So my job, your job, we're gonna end today that we need to work together to keep these patients alive for 6 months so we can get them a transplant. Now, if they go to transplant, do we transplant patient with mild disease, the first graph, or moderate disease? No, there's no significant improvement in survival unless they have severe disease, which means that transplant center gonna take these patients when they have severe disease. So we need to keep them stable enough for transplant, even when they get, till they get closer to severe disease, or send them early and get the patients early listing on the transplant. Look at these new data. Look at hepatitis C. Since we treated hepatitis C, we cure hepatitis C, we are not transplanting hepatitis C anymore. But look at the first column here. That's acute alcoholic hepatitis. The second column is the alcohol liver cirrhosis. So there's two, like I said, the acute liver on fire, they die. Can we transplant them? More centers are doing transplant, but they are trying to be selective. How many they transplant? 2%. How many transplants we do? 6,000 a year. 2% means 120 patients. So that's all what we do. I have 120 patients in San Diego every year. So you can imagine, I get 1 or 2 patients of mine transplanted, and a lot of other patients don't get it transplanted. Why? Because they might not survive the 6 months. I need your help to get them to survive the next 6 months. Here's the numbers of patients increasing after COVID. It became very obvious. We have a problem with young people, young females. They don't know that the alcohol can do this, and we can see that they are getting more listed. Liver transplantation selection for patients, just read the underlying, increasing evidence of benefit. Yes, liver transplant can save their lives, but there's selection criteria that has been implemented by Medi-Cal and Medicare in this state and other states. But in this state, they are very attached to the 6 months sobriety. Now, this is what I do. We get the patients, improve abstinence, ask for help the patient and the family, give them standard medical therapy. If they are not improving, we get them in clinical trials like the one we saw for DOR, and we put them on ECAD or plasmapheresis. However, we get patients that they deteriorate very fast and they die from us. Our goal is how we can keep them stable and alive. And if they are getting to the point of dying, with the proper support, we can get them to transplant. Summarize: acute alcoholic hepatitis, acute decompensation, mortality of the liver. Mortality is very high. Current treatments is limited because there is no FDA-approved therapy. However, we have tools that can keep the patient alive till they get the transplant, but there is barriers to the transplant. The Liver Society indicated that anyone who comes to a clinic in the primary care or GI or liver clinic, we should routinely screen them for alcohol use. And we're going to hear more about that from our speakers. We need to refer them to an alcohol use disorder treatment professionals. It should be done with professionals. That's why we are talking, and hopefully that we all work together to get to that point. And accordingly, there's a lot of data we're going to hear about, Matt, today that be considered to help the patient to stay sober enough, get to the point that if they need a transplant, they have the option of transplant. Let me finish by this slide. Alcoholic hepatitis patients, what are the challenges? Stigma. They go to the ER and everyone say he's an alcoholic. Forget it. You know, he will leave and keep drinking. The stigma is a major issue. We faced stigma in hepatitis C when we said, oh, hepatitis C means IV drug use. Don't, you know, when they stop using drugs, we'll treat them. We don't do this anymore. We need to address the stigma about alcohol. That the person who is drinking or over drinking, or there's genetic components, there's social components, there's family components. They have weak support systems in their family, in their society, in their surroundings, and in their medical support system. Because the doctors, all what they say, stop drinking, don't come back, we'll see you later. Non-supportive medical systems. We have, when they get into the hospital is begging me to discharge the patient every day. They need long hospitalization, costly services, poor training of medical staff. Oh, you're doing all this effort, they're gonna leave, they're gonna go back to drinking, and they come back to the hospital. We cannot think about it that way. Because when I stabilize them in the hospital, I wanna send them out to you guys to help me so we can be their support system. I was surprised when my social workers in my hospital told me, oh, this patient has Medi-Cal. He has no way to go. If they have Medicare, we can find them a place. But Medi-Cal, we don't. Today, we're gonna hear better information from my next speakers about that. Scarce clinical trials. These clinical trials, maybe we are the one center in Southern California doing this trial. We need these types of clinical trials in many places. And then the promotion of palliative care where the doctor says, oh, I don't think you will ever recover. Let me refer you to palliative care. So palliative care come and say, how are we gonna support you till you die? Please don't give up on your patient. And thank you very much.
Thank you so much, Dr. Hassanein. That was amazing. And I always remember an early conversation with you. And you said, you know, I can tell who has a chance to make it and who has a chance of not making it. And I said, how can you tell? He said, from the first visit. And I said, how can you tell? You said, who showed up with their mom? So the strength of a support network and a community of recovery is so important. And that's what a lot of our providers here with us subscribe to. Leading us into that discussion is Dr. Dunford, who's the medical director with McAlister Institute, a large provider with Medi-Cal clients, and similar to a lot of providers that are on the call today. So with that, Dr. Dunford, you are able to share your screen and you have the floor.
Okay. And hope everybody can see that. Are you okay? Scott, you able to see that?
Yes, we can see it.
Okay, great. There are a few topics I'd like to go over here today in about 15 minutes. Let's define alcohol use disorder, show the evidence of benefit for the medically assisted treatments that exist, talk a little bit more about why people are not getting treated, and then a brief explanation of what the drug Medi-Cal organized delivery system is, which is the reform effort that the state of California is implementing to try to improve substance use disorder treatment. And Dr. Hassanein alluded to the 14.8 million people on the left side here who now have alcohol use disorder in the country. And you can see the majority are men. 2.69%, by the way, are adolescent. And again, he reviewed the data about the impact of the pandemic and increasing 60% among those who had been drinking. A startling statistic is 1 in 10 Americans over the age of 12 has alcohol use disorder. Another thing to keep in mind when you're thinking of alcohol use disorder is there are a lot of other co-occurring problems that actually are diagnosed independent of their drinking disorder, including mood disorders and anxiety. And I just put this slide to show you how complicated it is and why there are many component parts to managing someone with alcohol use disorder. Up to 40% have a separate mood disorder, and up to 33% have an anxiety disorder that really will play havoc with them unless those things are dealt with in concert with their drinking. These are the DSM criteria for alcohol use disorder as of 2013, but keep in mind, these are applicable to opioid, to methamphetamine, and just about any other use disorder. Larger amounts than intended, unsuccessful efforts to cut down, excess time devoted to alcohol, strong desires, urges, cravings, we call them, failure to fulfill major social obligations, financial obligations, etc. Use despite getting in social difficulties, including getting arrested. Reduced social, occupational, and recreational activities, people starting to contract their lives. Doing things using in hazardous circumstances like driving a car, or despite knowing that it would be bad for you. For example, I know I have that fatty liver and I'm still drinking. Tolerance, meaning that you have to take more in order to get the same level of satisfaction. And then withdrawal symptoms themselves, either using alcohol or something like a benzodiazepine to relieve the symptoms. And the criteria for mild, moderate, and severe alcohol use disorder have to do with a number of those criteria. And you can see the numbers there. If you have 6 or more, you have serious alcohol use disorder. There are a number of treatments that work, including psychotherapeutics. This is what you typically see in a social model recovery program using cognitive behavioral, motivational enhancement, or other. There's one called contingency management. These are all psychotherapeutic approaches that actually have proven benefit. Similarly, Alcoholics Anonymous and the other 12-step programs have even been shown to be better as sustained abstinence and percent days abstinence than some of the psychotherapeutics through a large-scale Cochrane review. So those things cannot be forgotten about. It's critical that somebody is in AA and that they have somebody they can call and that they should be involved with psychotherapeutics. But at the same time, I wanted to talk about medication-assisted treatment because, in fact, there have been 4 drugs that have been approved by the FDA going all the way back to 1951, when what we oftentimes hear as antabuse, which is referred to as disulfiram, was first approved. Naltrexone, I'll mention more, 1994. Acamprosate, 2004, and the long-acting version of naltrexone, which we call Vivitrol, lasting a month, was approved in 2010. These drugs work differently. For those of you that are familiar with disulfiram, you know that it breaks down as alcohol is being metabolized, it goes to acetaldehyde, and disulfiram interferes with the next step, basically causing the buildup of acetaldehyde, which causes a whole variety of very uncomfortable symptoms, nausea, vomiting, flushing. It's one of those things we refer to as a deterrent drug. Having ever had this happen to you once, you never want to have it happen again. The other 2 medications, and I apologize for what I obviously did there. Let me see if I can go back to where I was. Oh, somehow I was able to unscreen share. Are you still all there? There we go. Let me go down.
Yep, we can say it again.
Let's go down here to, okay. The second drug is acamprosate, and acamprosate modulates the glutamine excitatory transmission in the brain. It should be started within 5 or 8 days, ideally, of the completion of withdrawal. And in fact, it may be treating a subclinical form of withdrawal that the client is actually still experiencing. And then the drug naltrexone, we'll talk a little bit more about, is it's useful in opioid addiction as well because it sits on a receptor called a mu-opioid receptor, and it inhibits the dopamine reward pathway that's common to alcohol and opioids. Acamprosate was studied also in the Cochrane Review, which is, a large number of randomized controlled trials, thousands of participants, and they compared it to placebo. And sure enough, acamprosate has been shown to reduce the risk of any drinking and to increase the cumulative absence duration. It takes 9 people, number needed to treat 9 in order to be able to get one effective cure. So that's the rough ratio. We avoid this in people with bad kidney disease. Naltrexone, which we said is also used in opioids, has been shown in a large number of randomized controlled trials also in this upper right-hand slide to show that, compared to placebo, the cumulative proportion without a relapse is significantly enhanced with naltrexone. And in this lower slide, if you had a score of 1 or greater, it showed a statistical advantage of naltrexone, again, over placebo. And you can see on the x-axis all of the criteria that qualify: drinks per day, relapse, the incidence of heavy drinking, and craving. Naltrexone outperforms placebo. So these are drugs that work. And going to the American Psychiatric Association's guidelines, you can see that they recommend acamprosate, naltrexone, and disulfiram, and that they're all FDA approved. And then I list a couple other drugs, topiramate and gabapentin, that are 2C, less evidence, but are sometimes used as well. So here's an article that was in the Union Tribune just, a couple of weeks ago that actually came out of the New York Times. If the alcohol abuse is on the rise and doctors too often are failing to treat it, and we have effective drugs, what's going on? These 3 columns that you see represent mild, moderate, and severe alcohol use disorder, just like I defined them. And as you go from the left to the right, you can see if you had 100% of people with alcohol use disorder and go to the far right, how many of them ever get treated? And then the answer is only 21% of the most severe alcohol use disorder ever get treated. There have been attempts to look at this and try and figure out what is it, at least conceptually, why somebody at the left-hand corner with alcohol use disorder who might be linked to care, screened about alcohol use, and actually get treated. And you can see a list here of all the potential barriers. Stigma, stigma, stigma being extremely important, but lack of provider time, lack of knowledge of physicians or providers in general. And I added another one, which is that what I'm going to talk about last year, which is that it's been a very confusing system to navigate for people, as well as, frankly, social workers and everybody. This was recognized in 2018 here in San Diego County when our county joined what's called the Drug Medi-Cal Organized Delivery System, DMC ODS. And this has been running throughout the state of California. Basically, counties may opt into the program. It's based on what are known as 1115 federal Medi-Cal waivers, which basically allows states to experiment with Medi-Cal to see if they can do a better job with the given amount of money to improve care. And what happened in California is that they elected to adopt and implement in Medi-Cal patients all of the services that the American Society of Addiction Medicine said would be important. And I've listed them all there, one of which is medication-assisted treatment. And on the right, the picture just shows that 93% of the Medi-Cal population of our state are actually living in areas where this is now ongoing. We are one of the providers for San Diego County, McAlister Institute, and this is my CEO, Gene, who's been in recovery for 67 years. We actually manage 1/3 of all the people in treatment for substance use disorders in the county. We have 27 programs, and we run the gamut of services from detox to residential for men, women, adolescents, recovery centers. We run the sobering center. We have sober living homes, the entire continuum of care that someone needs really in order to be able to get from, in some cases, the street all the way to recovery. But how do you access this? And if you haven't, you probably heard that 988 was implemented a few months ago in the country as an alternate access line. It is a great way to be able to find resources for alcohol and drug support. It's not just for suicide, crisis, those sorts of things that it does do that, but it is a good place to begin if somebody in this county, north, south, east, or west, doesn't know where the services are for their particular region. What happens in terms of getting people into care these days for Medi-Cal? There are essentially level 1, 2, 3, or 4. There are 4 levels of care, and there are subcategories of those that are defined based on the need of the patient. And the needs of the patient are defined through an extensive interview that's conducted in the 6 dimensions of their lives that really matter. Dimension 1, are you acutely intoxicated? Dimension 2, do you have biomedical conditions like hepatitis C or other things, diabetes? Dimension 3, do you have ongoing psychiatric issues or cognitive? Number 4, dimension 4, readiness to change. Do you have any insight at all that you even have an addiction problem? 5 being, have you had a history of relapse, or is there a problem with relapse? And number 6 is your living circumstances. And those things are all factored and put into a score. This just happens to be an example of score, the first dimension. But ultimately, you come up with a number that the counselor can say with confidence, this is what, based on ASAM criteria, you need in order for your recovery. If, for example, you don't need a residential facility, but you might need intensive services, then you might go to a place like this. This is down in South Bay. It's our Women's Recovery Center in National City. We have a whole range of providers, from counselors and psychologists, I won't read it all, and all different sorts of therapies. Until recently, we had to refer people for MAT, for the medications that we're talking about. The problem with that for a long, long time is that it's very inconsistent that the patient would ever get to the provider who would actually prescribe the drug. Again, some estimates as little as 1.5% of people in the US ever actually get treated. But we rely on our FQHCs in the community to try to be our partners, because we are not allowed to prescribe. Excitingly, though, in February of this year, we are finally going to be able, in our women's programs, for the first time, to be able to offer MAT services for alcohol as well as opioid use, by bringing a physician's assistant on board and doing it via telemedicine. This is the direction, again, that I see Medi-Cal in the state moving. More MAT, more support services. When people need residential care, that they should get residential care. This is a picture out in Lemon Grove of where our campus is for people who need acute withdrawal right off the street for alcohol or meth or whatever it happens to be. They are treated. We get our medications from the local emergency departments, and then we refer our clients to medically assisted services as soon as their withdrawal or during and throughout their stay with us, as we're transitioning them to another level of care. In conclusion, things can be worse than, for some people than others. We have a program, upper right-hand corner. This is our sobering center. This is actually the regional sobering center where law enforcement brings people under the influence to be able to sleep it off for 4 hours. And when they wake up from whatever they have been under the influence of, they meet with our counselors and navigators, and we try to direct them into services. And then for our most complicated patients, we, for many years in San Diego, have collaborated with other treatment providers and the Superior Court and a variety of others to run what's called the serial inebriate program. And this is just an example of one of many, many people who have gone from the streets before to a very healthy recovery from alcohol use disorder through this program. It's something I could give an hour-long talk about, but it's called SIP, and you may have heard about it. And it's a model program throughout the United States for those guys that have been living on the streets for up to 15 years and then had a new treatment provider that catered specifically to the needs of the homeless. So that's my short take on things. I hope it was short. I'm going to turn it over now back to Scott, and we'll hear some exciting stuff about what they're doing in the ER up at UC San Francisco.
Thank you so much, for Dr. Dunford. And, the intersection between what Dr. Hassanein talked about with liver disease and what you just talked about, although I'm the current executive director for the Liver Coalition, I'm the former CEO of the Mental Health Association here in San Diego County. So I really understand how we bridge together to wrap ourselves around these patients that we're sharing on this continuum. And that brings us to the next level, more tools that can make a difference when patients are struggling, their families are hurting, and it's hard to watch. And so every tool we have available, it needs to be activated. And to see those response times or those offer rates are very low. So Dr. Wang with Emergency Medicine out of San Francisco is going to talk about some of the research, which we hope pushes that envelope. We need to make this available, and he's going to talk about some of their outcomes, which we think will help us move in that direction. So Dr. Wang, welcome.
Thanks so much, Scott and Liver Coalition. It's a pleasure and an honor to be here. And I wanted to talk about this study that we conducted called ENACTED, Extended Release Naltrexone for Alcohol Use Disorder in the Emergency Department. I work in the emergency department at UCSF, and just wanted to say that out loud that I don't have any conflicts of interest. This is a slide that Dr. Dunford put up, and it represents the gap in treating alcohol use disorder in the United States. There's millions of patients who have alcohol use disorder, and the bottom line is less than 4 of them receive pharmacotherapy, effective pharmacotherapy. We think one reason why that is that many of these prescriptions are, many of these pharmacotherapies are prescribed by psychiatrists and addiction specialists and primary care physicians, but patients aren't always able to access these services. And if you're in a vulnerable population, if you have mental health problem or you're unhoused, the lack of access to these services is even more apparent. So this is the long-term goal of this research, is to expand access to naltrexone. The solution that we think may help treat the treatment gap is to initiate naltrexone in the emergency department. We think emergency departments are a missed opportunity to treat alcohol use disorder and should be leveraged as initiation sites. A few things about patients with alcohol use disorder in the emergency department. We take care of 5 million alcohol-related visits a year across the US. Patients who come to the ED for an alcohol-related visit are 3 times more likely to report heavy drinking and drinking consequences compared to those patients who go to a primary care clinic. So it may be that the emergency department is a teachable moment when someone comes with alcohol use disorder. And in Canada, they did a study and they looked at adult patients who had an ED visit, an alcohol-related ED visit, compared to those who hadn't, and they had a 4-fold increase in the risk of death. So coming to the emergency department with an alcohol-related visit, that's a marker for high risk. Even though we think of the emergency department like this picture where just people are lined up and it's just jam-packed with patients with COVID, I do want to reassure people that we have the infrastructure to treat pharmacotherapy. We have pharmacists that can help with details of the prescription. We have social workers that can help us provide follow-up and warm handoffs. We have substance use navigators through California Bridge funding. And there's another model for initiating MAT in the emergency department. That's buprenorphine for opioid use disorder. But I would say that we see, for every patient with opioid use disorder I see at UCSF, we see 4 or 5 with alcohol use disorder. So that was the objective of our study, was to conduct a pilot study, so a small study, making sure that we can give injections of naltrexone feasibly. So we wanted to make sure we saw enough patients to do it, and that we could give it, that we could order it, and our nurses would give it, and we could measure outcomes in drinking. And certainly this is, we are hoping to do this on a larger scale in a randomized trial. So we conducted a single-arm trial of extended release naltrexone at UCSF. We recruited participants during the first year of COVID, and over a course of 8 months. And the participants were active drinking adults with suspected alcohol use disorder. And these participants were referred by pharmacists and ED providers to our study. And we screened them with the Artice, which I'll talk to you about in a second. We made sure that they didn't have any exclusions to naltrexone. And if they gave us informed consent, we gave them a shot of injectable naltrexone, and then followed them up at 4 weeks and 8 weeks to give 3 injections total. Aside from just giving naltrexone, we also had case management by a substance use navigator who did motivational interviewing and reviewed past efforts to change drinking, and helped schedule appointments, and did referrals. So that was our intervention. And the main outcomes that we studied were drinking outcomes, which we measured by something called timeline follow back. So we asked participants to look at a calendar and tell us how many drinks they had on each day. And we measured daily alcohol consumption, and we measured the change in Artice scores and the change in WHO drinking level. We also measured quality of health and alcohol-related consequences. So we measured a number of aspects of drinking at baseline and then at 12 weeks. This is our flow diagram, and I just wanted to point out that we screened about 180 patients and ultimately 32 enrolled. So this is about 1 in 6 patients who we screened and approached agreed to injectable naltrexone. Many patients weren't interested. Many patients did not want to get a shot. They thought it might hurt. And I think many patients didn't want to commit to a month of decreased cravings. But 1 in 6 patients did enroll. The patients were, they were emergency department patients. They were young. So the median age was 43, mostly male. And we tend to see at Parnassus in the emergency department, we tend to see mostly white and Asian patients. Many of these patients had other substance use disorders like amphetamines, cocaine, about half of them. The patients that we enrolled had an Artice of 11, and I'll talk a little bit about that. And they drank about 8 drinks a day. So that's quite a bit. And the Artice is this 3-question screener that asks about, have you had a drink containing alcohol in the last year? And the most you could get is 4 or more times a week. How many drinks containing alcohol did you have on a typical day? 10 or more. And how often did you have 6 or more drinks on one occasion in the past year, daily or almost daily? So the median score in our patients at the beginning of their study was 11. So that's severe risk. And what I'm trying to point out is that the 32 patients that we enrolled were severe alcohol use disorder. And just going back to that graph one more time. So at the beginning of the study, they had severe alcohol use disorder, and they drank about 7 drinks a day. And their WHO drinking level was 4, which is the highest. And I just want to show you the after column, which is right next to the right here. And at the end of 12 weeks, their audit C-score went down to 2.5, which is low risk. And their median drinks was 0. And their WHO drinking level went from problematic to moderate. So for 4 to 1. This is a graph of, the number of drinks people had. And so at the beginning, people had about 8 drinks a day. And then at 2 weeks, it was down to about 4. In that 4 weeks, it was down to about 3. And at the end of 12, it was quite low. So we also talked to providers and staff and tried to understand what the barriers and facilitators of giving this medication was. And we found that most ED providers and staff did not realize that naltrexone is an established treatment for alcohol use disorder that's effective. And many providers were unsure how to identify and refer patients for treatment. And that's what we were dealing with. Some providers felt like the ED was too crowded and it was challenging to enroll patients. And that's what we sought to overcome. So I just want to wrap up to say that, we found that ED-initiated naltrexone is feasible, even during COVID, where operations in the emergency department were bananas. We were able to initiate treatment for 1 to 2 patients a week. And we retained most of the patients that we enrolled, and we observed that most of them had much reduced drinking at the end of 12 weeks, statistically significantly reduced amount of drinking. So this is a message of hope. And I do want to say that I really believe that we should be leveraged to intervene on alcohol use disorder and give naltrexone from the emergency department.
Excellent, thank you. And thank you for ending that on hope. I want to share and introduce Kioni, who's with us today, and he's going to share a little bit about his personal experience. So I think he's on if he turns his camera on and microphone. Kioni and I are personal friends for disclosure. So if it seems like I have a lot of personal information, it's because he's a friend that I've known, who I've seen him go through these struggles. And let's see, it's on the lower left hand of your computer screen. Kioni, you'll see a mute. There you are. And so Kioni, I met him when he was without alcohol entering his life. He turned on off mute as well. But Kioni, what was your life and living in San Diego like before you encountered this episode, which really brought you into the ER rooms?
No, I guess being out with friends and started drinking. I wasn't drinking like a lot, before COVID. Then COVID hit, and there was nothing else to do, and so it became a problem, obviously, to the point that everything was going wrong. Work, friendships, relationships, family, just pretty much everything just was impacted by the way of my drinking, to the point that I lost control of everything, to the point that all I wanted to do is drink. Excuse me. And I started taking, a friend of mine suggested to take naltrexone. And at the beginning, I was just kind of not really wanted to take anything because I believe I had it under control, but it wasn't. So the reality that, my denial of being an alcoholic and then not taking anything, then thinking that I had it under control, that was not the case, and it would never be. So taking naltrexone, it really has helped a lot. And I'm glad that I'm taking it and it's helping me tremendously. Not, drinking. I didn't even think about drinking. I still go out with friends and all that, but I don't crave any alcohol at all. Does it cross my mind? Yeah, but I don't. The thought of drinking, it just makes me nauseous, So I really believe in ultrasound that it's really helping me a lot.
Excellent. And thank you so much for sharing. I know it's scary to kind of share your story, especially, I always say you're one of the brightest stars that I know in our circle of friends that burn so bright. And so when I saw that captivate you, and someone that really took you to the emergency room and with your mom and family multiple times, how hard it was to watch someone struggle and try so hard and struggle, and then later to find out that this potentially could be available. And sometimes there was multiple ER room visits within a 4-day period, and sometimes different ER room departments based on Kioni's desire. So I think families and friends are looking for tools. Patients like Kioni are looking for tools. And so I think if someone had made it, kind of brought it up, it might have got the family and Kioni talking about it earlier, rather than really, I think it's almost been 2.5 years that you went through this deep dive into alcohol.
Yeah, it definitely it's been a couple of years, and not to blame it on COVID or anything, but I mean it's part of it. And it's, drinking heavily like that, it's a personal choice. And my choice was the wrong choice.
And how much sobriety do you have now under your belt?
It's going on 5 months.
Yeah.
Yeah, not drinking. Yeah, nothing. So I'm proud of myself, and and having friends around me that really help me mentally and yeah. So I'm glad that I have friends like yourself and other friends, family.
Excellent. Well, thank you, Kioni, for sharing that. I think I feel your hope and optimism for your future. I think that today's discussion was really about providing hope for patients and families that have this intersection of liver disease or alcohol use disorder, and how we can wrap services around them. We will record this video. It will be uploaded on our YouTube channel, which is the Liver Coalition's YouTube channel. And we invite you to share with others that were not able to make it today. Thank you to our speakers, Dr. Hassanein, Dr. Dunford, Dr. Wang, and then Kioni. And with that, let's bring hope to patients out there. Have a great day.